has begun.
Good morning, everyone. My name is Jordan, and I'm here to welcome you to our webinar today. I'm just going to do a little bit of a introduction for our speaker. Her name is Denise Everett. Denise Everett has dedicated her career to helping others through difficult times and has spent more than 25 years as a community leader in the counseling and therapy fields. Prior to her current position as Executive Director of Quest Counseling and Consulting in Reno, she served as project director for the Frontier Recovery Network at UNR, chief executive officer for Principal Consulting, and executive director for Sage Wind, an adolescent treatment center. She received a bachelor's degree in social psychology, a master's degree in counseling and educational psychology, and a certificate in nonprofit management from the University of Nevada, Reno. As well, Denise is a licensed alcohol and drug counselor and a licensed marriage and family therapist. Having worked in the field of substance use disorders and mental health for decades, Denise has taught addiction classes at the community college and university level, in addition to presenting a variety of 1- and 2-day workshops on addiction and treatment issues. Her expertise has offered insight while serving on several boards of directors, including Washoe County Children's Mental Health Consortium, Washoe County Department of Social Services Advisory Board, and the statewide Strategy for Drug Control, Violence Prevention and System Improvement Advisory Committee, State of Nevada Office of Criminal Justice Assistance. She has also received several awards, including the Nevada Bureau of Alcohol and Drug Abuse John Chappell Award in recognition of service commitment and innovation in alcohol and drug treatment, and was awarded Administrator of the Year by the Truckee Meadow Human Services Administration. We are so grateful to have her with us today. And we're going to just show you a few of our things today. Our learning objectives are as follows, and this is our disclosure policy with our faculty and our CME committee today. So without anything else, I want to introduce Denise to you.
Well, good afternoon. I think it's afternoon, and I have to figure out how to use this mouse so I can advance my slide. That was a wonderful introduction. I was a little uncomfortable there for a few minutes. I am obviously not a medical professional, but I've worked in the field of substance abuse disorders and mental health for over 25 years. And I also identify as a person in long-term recovery. So I feel like I have both the educational and experiential background, and although it's been many, many years since I've used alcohol or an illicit substance, I don't think it's anything that one tends to forget. And I have to remind myself that where I came from. And so when I work in the field, I know I'm an administrator now, but I keep a limited caseload, and I also do group. I don't ever want to get too far away from my roots, and I want to remember why I'm doing this work, and I want to work with people that have had similar issues to what I've had, and also folks with mental health conditions. And at Quest Counseling, we do a lot of work with folks with co-occurring disorders. So they have a substance use disorder combined with at least one mental health condition. And our focus at Quest is actually adolescents and young adults, ages 18 to 24-ish, although we do work with families and couples, and we do marriage counseling and a wide variety of activities there. We also have a transitional living facility for adolescent boys ages 13 to 17, and they live at the home here in Reno, and then they're transported every day to our outpatient office to receive individual, group, and family counseling. So I wanted to start off today talking a little bit about the state of Nevada. And I was going to make a joke about, I'm just going to read the slides, but I'm really not. I'm going to reference the slides and then, fill it in with a little bit more information. So Nevada has a population of about 2.5 million people, and the National Institute of Health says that approximately 8% of people in the U.S. have drug and alcohol issues, which would mean that would translate to more than 227,000 people in the state of Nevada. And unfortunately, what happens, at least in Nevada, is that most people don't get help for their addiction issues until they're involved with the criminal justice system. Like, we have contracts with, we're the sole provider for Washoe County Juvenile Services. We also do an entry-level drug court program. We do an adult reentry program where folks who are incarcerated are released early. It's more like an early release program, and under certain conditions, that they live in a halfway house for approximately 3 months, that they come to Quest for counseling, those kinds of things. So a lot of folks don't get involved with counseling until they're involved in the criminal justice system. And however, research has shown that people who enter treatment under legal pressure have outcomes as favorable as those who enter treatment voluntarily. So a lot of folks that we get into treatment actually do really well during the treatment process and after they're discharged. Now, this is purely anecdotal, and I don't have any research on this, but I've worked with both the adult and the adolescent populations. And what seems to be more the norm than not is that if an adult is going to relapse after treatment, they tend to put together some period of recovery and then relapse, and then very oftentimes realize that the path that they're going down isn't serving them any good purpose. With adolescents, it seems to be in the reverse. If they're going to relapse, they do it immediately after treatment, right when they get out. And then oftentimes realize that, they're not going to achieve what they want to in life. They're not going to continue to use, and at a certain point, it's no longer a choice. It changes your brain chemistry, and it's more, that's when the compulsion kicks in, but I'm going to talk about that in a few minutes. At any rate, in 2013, there was about 9,000 people admitted for substance abuse treatment in the state of Nevada, which is hovers right around 4%, which means that, 96% of people who could have used treatment did not get it. So that's pretty consistent across the entire United States. There's still a great deal of stigma and discrimination around folks who are involved with alcohol and illicit drugs, or even legal drugs, but who are abusing them. So there's a dearth of programs too, especially in the state of Nevada. And what happens oftentimes when people are admitted into treatment is that they are not sure, what it is that they want to do, or what they're going to get out of treatment, and there tends to be, sometimes a rather high dropout rate. And so we have to be very careful as counselors to make sure that we're engaging the clients, and that they can see the value in participating in treatment regardless of what level of care they're in. So I just want to say that you will have patients who have these issues, and it's important to be able to recognize the condition and to refer to the appropriate treatment. And at the end of my presentation, I have several different options of where you can actually refer folks that you believe have some kind of issue with drugs or alcohol. So, substance abuse negatively impacts health in a wide variety of ways, including lung or cardiovascular disease, stroke, cancer, mental disorders. One of the things that, I find fascinating is that, alcohol, which is our legal drug, actually is so negatively impactful on one's physical health. It impacts every single organ in your body that, what I've read is heroin is actually a cleaner drug. It's less damaging to your organs than alcohol is. So And then, of course, you know that many drugs of abuse, including alcohol and tobacco, can be deadly. So it kills many people every year in the United States. So right now, excessive alcohol consumption is the third leading cause of preventable deaths in the U.S. after tobacco use and poor eating and exercise habits, according to the CDC. And we also know that it's the leading cause of mental retardation in the United States. So there's a lot of instances of fetal alcohol syndrome, hence all of the warning labels on alcohol and signs in women's bathrooms, in bars, that alcohol can be damaging to your fetus. And we work really hard on getting the message out, the prevention message, that alcohol consumption while you're pregnant is a really bad idea. And also, for healthy men under age 65, it's recommended that they have no more than 4 drinks a day and no more than 14 drinks a week. And for women, it's 3 drinks a day and no more than 7 drinks in a week. And a lot of people don't realize that. So I think that's oftentimes really good information to give to our patients and our clients. What an article in the Washington Post that I read recently stated was that overdose is now the leading cause of accidental death in the U.S., especially for 35 to 54-year-olds, and that it's the second leading cause of death for younger folks. I actually would have thought that was reversed, but that's not according to the information that I read. And I think that has a lot to do with older folks being prescribed pain medications. So fatal overdoses from opiate medications such as oxycodone and hydrocodone and methadone have quadrupled since 1999. And what I've read recently is that although the prescription for pain medications has quadrupled, there hasn't been any change in what Americans have reported as their level of pain. So it's just, really interesting, and I don't want to blame the pharmaceutical industry and marketing, but I can, it doesn't hurt to sort of speculate if maybe some of it, the issue comes from, really pressuring physicians to use products that, maybe something else would work just as well. So in stats from the Substance Abuse Prevention and Treatment Agency in the state of Nevada, admissions data in 2012, which is the latest that I could actually get information for, it indicates that stimulants, including methamphetamine, were the primary drug of choice, followed by alcohol and then marijuana. And I could talk for days about marijuana's impact on our adolescent population. We're seeing more and more folks, kids, using marijuana because of the perceived, the perception that it's not harmful, that because states are, legalizing marijuana, for recreational use, and the state of Nevada has legalized marijuana as a prescription, as a medication, that it must be okay for you. And what happens with adolescents especially is that their brains haven't finished developing. And so when they use illicit substances and alcohol, it really impacts their brain development. And so, we try to work really hard with educating our kids on letting them know what the impact is of them using drugs and alcohol. So anyway, Nevada's percentage of alcohol dependence or abuse among 12 and older, according to the Substance Abuse and Mental Health Services Administration, is similar to the national average. And then almost every day, almost 7,000 people are actually treated in ERs for using their drugs other than the way they're prescribed. And the most, according to the CDC, the most common drugs involved in prescription overdose deaths are Vicodin, hydrocodone, OxyContin, oxymorphone, and methadone, especially when it's prescribed for pain relief. So we have, quite an issue. And like I said, I've been in the field for quite a while. And the last probably, I want to say 7 or 8 years, there's just been a huge influx in folks using heroin, and I have a couple of gentlemen on my caseload, and our experience at Quest is that it's frequently the drug of choice for young adolescent or young males, ages 18 to 25, 26, and the folks that I have been working with have started off by using pain pills. One was actually prescribed the pills. The other one got them from a friend, and I believe that he was at a farm party, and they also talk about it as being like fiddle parties, and where everybody gets a variety of drugs, pills especially, and put them in a bowl, and people just take them randomly. It's very, very dangerous, and it's just, something that occasionally, happens in our area. So, 4 out of 5 people today who start using heroin began their opioid addiction on prescription opioids. And then, although that research shows that 20% of patients in primary care settings have alcohol abuse problems, they're actually diagnosed less than 50% of the time. And, very oftentimes, I think it's really hard, it's very difficult to ask your patient or anybody about their alcohol or drug use. And for me, it goes back to, the stigma and, the issues around the morality of using drugs and overusing alcohol. And my hopes would be that primary care physicians and physicians of any type actually look at this as a disease. And in my experience, folks start out with pain pills, then they become addicted, and then they get too expensive, or they can't find them. Very oftentimes, like people get them from friends and family, and they either are given them or they buy them from their friends who have been prescribed pain medications. And also, when they can't find it anymore, heroin is so much cheaper, and it's become so much more prevalent with the introduction of smokable black tar heroin, which, several years ago you couldn't actually, you could only inject heroin, and now there's the smokable type. So I have clients that are very proud that they have never used a needle, but they're smoking heroin, several times a day. So it's just really, it's really interesting what the perception is. And for a long time, I think that the United States thought we had the heroin epidemic under control. So even on, like the Youth Risk Behavior Survey that they do every other year through the CDC, didn't even have questions on it about heroin, because they felt as though folks weren't using it anymore. And it's just become very, very popular in the last several years. And so we've had to work really hard with, education, prevention, and treatment. And we have a psychiatrist at Quest Counseling, and he took the classes in order to be able to prescribe Suboxone, so we can help our youngsters that have heroin issues. So even though 88% of primary care physicians ask their patients about alcohol use, only 13% use standard screening tests. And I'm going to talk a little bit about, some screenings that are out there that are relatively easy to use, don't in the office or something along those kinds of lines could, use the screening tools in order to figure out which of their patients have problems and what don't. And then I have a little slide up here from the National Institute of Drug Abuse about the estimated economic cost to society due to substance abuse and addiction. And it comes out to a lot of money every year. And this is a few years old, and I'm not sure, it's in the 2000s, but I'm not sure quite how old it is. And it really does cost our country a lot when folks are engaging in these kinds of activities. So interventions. I'm getting a little ahead of myself. Hang on just. Okay, interventions in a primary care situation can be very effective. Sometimes a family doctor simply saying, I'm concerned about your drinking, is enough intervention to get the patient to reduce their drinking, provided that patient does not have a full-blown, severe dependence on the alcohol. And it's surprising how often people will listen to their physicians and do what's suggested. And if their doctor says that they're concerned, it can oftentimes be enough of an intervention to get the patient to actually reduce their drinking. Another issue to consider is co-occurring disorders in the office. And the Journal of American Medical Association reports that approximately 50% of the people diagnosed with a severe mental illness are affected by substance use disorders, and 37% of people with alcohol use disorders and 53% of people with drug use disorders have at least one serious mental health illness. So you need to be able to look at that issue too. It's difficult to know which came first. I mean, it's the whole chicken and the egg thing, but it's important to treat the two concurrently. And when I was first in the field, in the late 80s, I worked at NASAC, which was the Northern Area Substance Abuse Council, and we were on the grounds of the Northern Nevada Adult Mental Health Services. So we actually were on the grounds of NAMS. However, the policy at NASAC was that we would not take anybody into treatment who was on any kind of psychiatric medication. So it made absolutely no sense whatsoever, because very oftentimes folks will be using drugs and alcohol in order to self-medicate their mental health condition. And we were refusing to look at the fact that perhaps they wanted to not do that anymore and take a medication that would help them control their mental health issues, and it was just a merry-go-round, and it was serial treatment. They would get treatment for their mental health condition and then try to get substance use disorder treatment, drug and alcohol treatment, but we wouldn't take them unless they went off their meds. So of course when they went off their meds, then their symptoms would bubble up again and they wouldn't be able to control their mental health issues. So it was really a sad state of affairs. Thank goodness, while I was still there, we actually changed the policy and allowed folks in that were on medication. So I was very grateful for that. So a review of studies reported that intervention participants reduced their alcohol consumption an average of 13 to 34% compared with a control group, and that brief interventions may reduce mortality rates among problem drinkers by an estimated 23 to 26%. And that's from the National Institute on Alcohol Abuse and Alcoholism. So I think it's well worth our while to make sure that we ask our patients and our clients about their drug and alcohol use, because I'll occasionally get somebody in that comes in ostensibly for anxiety or depression or even marriage counseling, and oftentimes in the course of either working with them or the initial assessment, I'll get an inkling that, there's something else going on here, and perhaps drugs and or alcohol are involved in the situation, and I have to be able to make a determination about, what I'm going to ask, how I'm going to ask it, and what I'm going to do about it. So at any rate, as most of you know, most drugs of abuse are addictive. Addiction is a chronic, relapsing disease characterized by compulsive drug seeking and use despite negative consequences and by long-lasting changes in the brain. So one of the things that I like to talk to my clients about is the fact that they are not bad people trying to be good. They are sick people trying to get well, and that they've been taking a drug or drinking long enough that they've actually changed the chemistry in their brain. And I was talking to our psychiatrist today, as a matter of fact, and he was saying that he read a fascinating article in a psychiatric journal about working with clients with alcohol problems with a game where they actually had to, they were shown pictures that would trigger or remind them of drinking, like a bottle of alcohol or a drink, in a glass or something along those lines. And the point of the game was that they were to minimize that that representation to be as small as they could. And then they were shown, something that was more neutral or positive that had nothing to do with alcohol, like, a piece of cake or a amusement park or something along those lines, and to make that bigger. And what it appeared to do, according to this research article, is translate into the real world that in the reward center in the brain, it would minimize the impact of the alcohol and maximize the feel-good effects of things other than alcohol. And it was only done with alcohol. It wasn't done with drugs. But, he and I were talking about how we don't have a huge arsenal of tools in order to work with folks that have, substance use disorders, and that something like a computer game, I think, would be absolutely wonderful, especially with our younger folks, because they're so used to working with technology. So it's, something I definitely am interested in and want to look into, but it's, something that we all, that it makes sense to have some information about what's going on out there in the world of treating substance use disorders. So people that are addicted have strong cravings for the drug. It makes it very difficult to stop using. Most drugs alter a person's thinking and judgment, which can increase the risk of injury or death from drug driving or infectious diseases, unsafe sexual practices, needle sharing, all those kinds of things. And we're back to also with adolescents impacting their prefrontal cortex, which is the home of executive functioning and planning and those kinds of things. When they are using drugs and alcohol, they're impacting their brain development. And so it's, what the research says is that if you start using drugs and alcohol, at 15 or younger, you're 4 times more likely than someone who waits until they're 21 to end up with some kind of issue around drugs or alcohol, because it just so greatly impacts what's going on in your brain. The longer we can get somebody to wait to use, the better off we are, and the more likely they won't end up with some sort of issue around drugs and alcohol. So I have no issue whatsoever with, social drinking and that kind of thing. It's folks that have, demonstrated that they have had a lot of negative consequences by their use, and their lives are not going in the direction that they want it to. It's not even the direction that I want it to. It's the direction that they want it to. So, and then, of course, drug use during pregnancy can lead to neonatal abstinence syndrome, where the baby can suffer from dependence and withdrawal symptoms after birth, which is very distressing for everybody involved. So, the American Medical Association declared alcoholism as an illness, in 1956. So that was almost 60 years ago. Oh, I've got a slide where I can't read part of it, but that's okay. One of the things that I am frequently asked is, what are the rates for, success rates, like for drug addiction treatment? And, what I tell people is that what the research shows is that the recovery rates are very similar to those of other chronic conditions like asthma, high blood pressure, diabetes, and this is according to the National Institute of Drug Abuse. So, 30 to 50% of people with type 1 diabetes fail to stick with their treatment plan. 50 to 70% of asthma sufferers fail to take their meds or, make recommended lifestyle changes. So, 50 to 70% of people with chronic high blood pressure don't take their hypertension medication as directed, and then 40 to 60% of drug addicts will relapse. Relapse, to me, does not equal failure, because very oftentimes it takes more than one treatment episode or one counseling episode for somebody to understand and have it sink in what kind of lifestyle changes they need to make. And my personal belief, and I'm not sure that I've ever read anything about this, but I believe that it's cumulative. So I actually wanted to ask a question, and I was going to have Jordan bring up a question that I wanted to ask you guys. And, you know, are there a couple of medications that can be used for substance use disorders, and do you prescribe them? Why or why not? You know, if you can type in your answers, I'll keep going, but I'd love to see kind of from, you know, the medical field, kind of what your thought process is around using medications for substance use disorder. So if you'd be willing to do that, I think that would be great. And then you can hopefully see each other's answers and, you know, maybe have, you know, a little dialogue with each other if you'd like, you know, that kind of thing. And if not, that's fine too. So I want to talk about screening and assessment, because this can be incredibly uncomfortable. And the more you screen, the more comfortable you're going to become with it. So if you can view it like any other screen, like for high blood pressure, cholesterol, those kinds of things, it's just, you know, really helpful, and take the whole stigma piece out of it. And there's, you know, there's a lot of different ways that you can go about it. I actually, in my doctor's office, they often ask about domestic violence. When I go in and the nurse is taking my blood pressure and my temperature, she'll ask me, what she prefaces it with is that there's going to be a study, they're participating in a study about domestic violence, and, you know, have I ever been, you know, have I ever been injured or abused or hurt in a domestic situation? And they'll ask me a series of questions, and, you know, they'll couch it in a way that's very non-offensive, not like they're accusing my husband of anything, which I greatly appreciate. So, you know, there's several different ways to do this. So you can, you know, kind of use your imagination, and I'm going to give you a lot of different perspectives about different ways that you can screen folks. And universal screening for alcohol problems can be deducted concurrently, you know, with all your other screenings. Just lump it in with everything else, like it's just, you know, a normal routine part of what you always do. And then by systematically screening every patient with a validated screening tool, you can effectively identify your patients that with, you know, risky or dependent levels of alcohol use. So, you know, somebody, you know, replied that they use Antabuse because of the negative feedback patient receives if they drink while on the medication. And I actually had a client not too long ago that was on Antabuse for continued to see me for another few months and was doing really well. And I've gotten reports. I actually know one of his family members. Reno is a very small town, and my understanding is that he's continuing to do well. So, you know, Antabuse can be a wonderful adjunct to what you do in your practice. And screening is especially important for, you know, a certain type of patient, and you know, a patient who's pregnant or trying to conceive, at risk for binge drinking or heavy drinking, have health problems that might be exacerbated by alcohol, or, you know, using their drugs improperly, have, you know, chronic health problems, and that maybe aren't responding to treatment, and you have some suspicion that there's something going on, or, you know, they've told you about social or legal problems that may be caused or worsened by alcohol use, you know, like they're having marital problems, or, you know, if they've gotten a DUI recently, or those kinds of things. So, you know, you need to, you know, pay attention to your patient mix. And there's certain folks, I think, that it's really important to be able to do a screening and figure out whether or not, you know, a brief intervention is in order, or perhaps a referral to a resource. So I think that, the other thing I wanted to mention about prescribing pain medication too is that very oftentimes it's very helpful to ask your patients to make sure to lock up their medications. And there's all kinds of lock boxes that are available, especially if they have children or adolescents in the home or adolescents that visit. Because I've had a few kids that, where they get their pills is they go over to their grandparents to visit and go into their medicine cabinet and just take a few. So their grandparents probably wouldn't even notice. And so if you've got, patients who are taking medications and they have, especially ones that have young people that are coming over, you might recommend that they have some sort of system where they can lock them up. So, what you can use for screening, you can ask a single interview question. How many times in the past year have you had, 4 drinks for a man or 3 drinks for a woman in a day, and see what they have to say. A lot of times people don't realize that, that's, over that is actually considered binge drinking if you do it, more than 1 day in a row. Then the single question can be used at any time or with the audit. And the Alcohol Use Disorders Identification Test is it's a questionnaire that was developed by the World Health Organization, and I reprinted it. You can reprint it with their permission. But they just ask, it's a series of 10 questions, and this can be done prior to you going into the exam room, those kinds of things. So you can use it as an adjunct to your normal screening, and perhaps have the back office person or the nurse look at the questions and see what the total is, and if it's if it's a really low score, when you actually go online and look up the audit questions, it tells you how to score it. If you get a low score, then you could say something about, it's nice to see that you're not overdoing your alcohol consumption, or if they are, it's like, I'm kind of concerned. Let's talk about, your level of drinking. And I know that, very oftentimes you don't have much time when you have a client, a patient, in the office. You are, pressured by, managed care and everything else. And I feel as though I'm asking you to just do one more thing that you don't have time to do. But I personally believe that this is an incredibly important area to address, because it impacts so many different levels of a person's life, including their physical health. So I just, am grateful that I have this opportunity just to talk about this a little bit. So I really do believe that, at the very least, if you could just ask the one question about, how much folks drink in a day, that can be incredibly useful. But there's a lot of different screening tools out there, and there's a document called Alcohol Misuse Screening and Behavioral Counseling Interventions in Primary Care, and I have I listed the website up there. And you can also consider using screening, brief intervention, or referral to treatment, which you use screening as a way to determine whether or not somebody has an issue, and then whether or not they need more intensive care. So, a brief intervention from you be helpful, or do they need referral to treatment? And it's interesting because I think JAMA just came out with a couple of 1 or 2 research articles recently that indicated that SBIRT doesn't work as well for drug using as it does for alcohol use. And I haven't really, looked into it all that well. I just know that there's a lot of history and research behind SBIRT use with alcohol. So it's something that, I would definitely, recommend people look into if you have that opportunity. And it's comprehensive. It's an integrated public health approach, and it's used in primary care centers, hospital emergency rooms, trauma centers. I actually went down to San Diego several years ago to watch some folks how they did it in their system, and how they integrated it into what they already did in their clinic. It was a it was a healthcare center in San Diego, and they did an excellent job of figuring out, who was at low risk, moderate to high risk, severe risk, those kinds of things. And, at that point, what they would do with them, and they just had a checklist about what what the outcome would be, or what the outcome was. And that way, when the patient came back to the clinic, they could follow up because, they had all the information already in the chart. And it just seems like a system that worked really well for them. So, it assesses severity, and it focuses on, brief intervention focuses on, increasing insight and awareness for your patient. And then, of course, referring to treatment. And then, one of the other things I think is really educational for folks is explaining to them what a standard drink is. It's a 12-ounce beer, a 5-ounce glass of wine, 1.5 ounces of hard liquor. A lot of folks will say, well, I only had a drink last night, and come to find out they had a huge tumbler of wine or alcohol. So it's interesting. And then that also can change their answers around when you ask people how much they've had to drink. When it's 4 drinks for men and 3 drinks for women, you might want to ask them what size their drink was too, because sometimes people, a half a bottle of wine to them is a drink. So it's something else that we need to consider when we're talking to folks about, their consumption of alcohol. And I found this great little thing online, and it's alcohol screening and brief intervention for youth. So for those of you that, are either pediatricians or work with a lot of adolescents in your practice, this practitioner's guide was developed by the NIAAA and in collaboration with the American Academy of Pediatrics, and I think you can get CMEs for it. So I just wanted to throw that in there so you could look it up in case you had any interest in doing that and learning more about, screening and brief intervention with kids, with youth. Screening for drug use. Be cautious in prescribing narcotic painkillers. Since between 1999 and 2013, according to the CDC, the amount of prescription painkillers prescribed and sold in the U.S. nearly quadrupled, but there hasn't been an overall change in, what people report as their amount of pain. But it seems to be leveling off. According to the research, it seems to be pretty much leveling off, which is really nice. And then, the 20 to 30% of opioids prescribed for chronic pain are being misused, and according to the Pain Journal, the rate of addiction is probably right around 10%. And one of the things that I find really interesting too, especially around pain medication, is that physical dependence and addiction are not the same thing. And so, and sometimes it's very hard to discern which is which, because many of these products, opioids, are so addictive that the person might be physically dependent upon the substance, but not actually, experiencing negative consequences or using compulsively or not as prescribed. So those kinds of things need to be, teased out with a person. And my husband is an RN and has worked in several emergency rooms, and he said, essentially that addiction is the primary cause of people showing up in the ER. They're either, there's drug searching, or they've been injured under the influence, or they've gotten into a fight when they've been drinking, or they fell off the ladder after they had a few beers. So, he calls it his, job security. Addiction is essentially his job security. So it's just, and now he works for the Department of Corrections, and so it's even more prevalent there. And so it's really interesting, where substance use disorders and addiction will lead folks. And that's why I think screening and maybe intervening very early on in the process can be extremely helpful. So the ASSIST method, the screening test, is a package that's developed to help primary health care professionals. And it was also developed by the World Health Organization, and the manuals are available in Spanish and online. So the package includes 3 different manuals, and it's a little bit more involved than, some of the other things that we've been talking about, so you may not have a lot of interest in it, but I just wanted to give you the information in case it seemed, if you wanted to introduce it more into your practice. And so what comes next? So you're doing a screening and you find out that, somebody has an issue. So the direct involvement of physicians and other healthcare professionals in identifying and treating alcohol use disorders is possible, practical, and necessary. So I'm going to talk a little bit about medications, and for the most part, you guys know a whole lot more about meds than I do, but these are the ones that I'm familiar with. And, when we're talking about medication-assisted treatment, I think I had another question having to do with this part of it was back to the couple of medications that can be used for substance use disorder. So if anybody comes up with anything else, you can certainly fill in the blanks here. But a patient who reports one or more heavy drinking days in the past year or has an audit score greater than 8, should receive further assessment. So you want to get, patient history, maybe a physical exam, do some lab testing, check their liver, functioning, those kinds of things. And be especially aware of adolescents, young adults, older adults. There's been a proliferation of issues with people, the baby boomer generation, ending up with problems around combining medications with drinking, those kinds of things, and then pregnant and postpartum women. So you really want to pay some attention to that. And, when you actually use medication-assisted treatment as part of a comprehensive treatment program, it's any, medication treatment for substance use disorder that includes a pharmacological intervention. So you want to, it's been shown to improve survival rates, so people don't overdose and that kind of thing, increase retention in treatment, decrease illicit opiate use, decrease hepatitis and HIV seroconversion, decrease criminal activities, increase employment, and improve birth outcomes with perinatal addicts, according to SAMHSA. And some of the things that folks use in order to do medication-assisted treatment would be, acamprosate, calcium, and Camprol is the trade name for that, and it's indicated for folks who have difficulty stopping drinking but have just quit or recently quit. They need to not have the alcohol in their system. They need to have been detoxed. So you have to be careful with that. And also it can impact the kidneys, so you have to be careful about kidney issues. And then antabuse, we've mentioned it's for people who want to remain in a state of enforced sobriety, because it really has some very negative effects if you drink. And then you have oral naltrexone, and it's been indicated in the treatment of alcohol dependence and opiate dependence. And then there's the extended release injectable naltrexone, and the difference between the two is that the oral naltrexone, you have to be your patient has to be very medication compliant, because it's a pill and they need to take it every day. It's a tablet. And then the injectable naltrexone takes a day or two to start working, but lasts for like a month. However, the oral naltrexone, depending on the pharmacy, is anywhere from like $11 to $60 a month, and the injectable can be up to $1,100 a month. So it's incredibly expensive, and only some insurance companies will pay for it. So it's not used nearly as often as the pills, but it works better because it's in the system and you can't get it out of your system. So there was a study in Australia that I read not too long ago, and it said that Camprol in conjunction with naltrexone, used in conjunction with cognitive behavioral therapy, had the best effect, worked better than either of the two drugs alone and with no therapy. So I thought that was interesting. And then, naltrexone is an opiate antagonist, so it blocks the effects of the alcohol or the heroin, and Vivitrol is the trade name for the injectable naltrexone. And I've had a client that was on that, but his insurance actually paid for it, so that was a good situation for him. So medications for drug abuse, for opioids, there's methadone, buprenorphine, and naltrexone sometimes, and tobacco has a lot of formulations of nicotine replacement therapies, patch, spray, gum, lozenges. Sometimes Wellbutrin is used, or Chantix, those kinds of things, which are prescription medications. The other things, the patch spray gum and lozenges are now available. They used to be prescription, are now available over the counter. And then amphetamines, like if you have somebody who's, dependent on methamphetamine, there's no medication assistance for the actual dependency, but there are some medications that can be used for short-term depression and cravings, and benzos can be useful for anxiety or irritability, and then, nutritional supplements, getting, obviously treatment, those kinds of things. So there's a lot of research going on right now to see if there's anything that can help folks that have amphetamine or methamphetamine issues. And, medications should be prescribed as part of a comprehensive treatment approach. That includes counseling, perhaps referral to a psychiatrist, psychologist, professional counselor, social support, maybe participation in 12-step programs like Alcoholics Anonymous, Narcotics Anonymous, or other, mutual help programs. And when you participate in treatment and you have participation in a 12-step program, it, according to research, greatly improves your treatment outcomes. But some people are very adverse to those, to support groups. So there's others out there, that folks can tap into, and hopefully if they're in treatment, their counselor can help them find some sort of social support that can help them, get over or be provided with the support that they need in order to recover from, their drug of addiction. And I wanted to do a couple of citations. A lot of the information that I got was from SAMHSA. And then, there's a couple of blogs in the Washington Post that I really like that, I got information from. And then I wanted to throw in some resources for gambling because there are so many of our folks, when they have one type of addiction issue, oftentimes that might come hand in hand with another type of addiction issue. And so I had some information for Southern Nevada on here, but I don't know what happened to it. But at any rate, the Reno Problem Gambling Center does an excellent job with counseling. There's always Gamblers Anonymous, which is GA. Very oftentimes, women who are recovering from drug and alcohol issues will turn to food. And so there's Overeaters Anonymous, there's Food Addicts and Recovery Anonymous, there's other places that they can go. And I don't know if anybody had an opportunity to read the article in this week's Reno News and Review, but it was about a woman who was a recovering meth addict, and she actually had to move out of the Reno area in order to recover, and ended up replacing meth with food and ballooned up to 330 pounds. And so she talked about that in the article, which I thought was really interesting. But very oftentimes, if people have a compulsion in one direction, they'll take it in another direction. And I've known more than one heroin addict who replaced heroin with alcohol because they're both central nervous system depressants and that kind of thing. So some other places, resources that you could refer folks to in, again, we're just in northern Nevada, but Quest Counseling, Willow Springs Hospital, Bristlecombe Family Resources, Family Counseling. Now, the Substance Abuse Prevention and Treatment Agency, SAPTA, is for the entire state, and they have all of the state-funded programs listed on their website, so that's a great resource. Or you can just call them if you're in a specific area and you just want to call them and find out, what you should do in reference to folks that have problems. And this is only the tip of the iceberg, okay? So there are, there's the Salvation Army program, there's the Empowerment Center in Reno. The Substance Abuse Helpline here is actually area code 775-825-HELP. So it's 825-4357. And it is run through Join Together Northern Nevada, which is JTNN, which is helping to support this webinar, actually. And it's a prevention coalition to help prevent the negative impact of substance abuse in our area, along with the crisis call center. So JTNN and the crisis call center operate the substance abuse helpline, and again, it's 825-HELP-4357. So I really wanted to make sure that you guys had that information. And the other thing that I wanted to mention is that I would definitely, if you're working with somebody with a substance use disorder and their family members are involved in the process, and they're with them at their appointment or in the waiting room, I would strongly suggest recommending Al-Anon for adult family members and Alateen for teens or children of people with substance use disorders. And here's some more. So I just, like I said, I wasn't being completely, I didn't list everything that's available in the entire state, but I just wanted to make sure that you had something in black and white that you could refer to if you needed to send someone to a resource. And then I think it's these particular folks have some wonderful information out there for primary care folks. So Helping Patients with Alcohol Problem, a Health Practitioner's Guide. It's put out by NIH. And then Assessing Alcohol Problems, a guide for clinicians and researchers. Screening for Drug Use in General Medical Settings is put out by NIDA. And even just going to the NIDA website or the NIAAA website, both of them have a ton of information around addiction issues, both concerning alcohol and other drugs. And then, of course, the Substance Abuse Mental Health Services Administration. And they also have a treatment locator. So if you go to their website, you can find the treatment locator and find any registered treatment program in the entire United States. And so SAMHSA is a wealth of information around all kinds of issues having to do with, what we've been talking about for the last hour. So, that is pretty much my presentation in a nutshell. And I believe on the very first slide, I put my contact information. So if you have any questions or concerns or, need more information or want to get more information on resources, please feel free to call me or email me. And thank you very much for allowing me to spend the last hour with you. Take care.
Thank you so much, Denise. That was an absolutely incredible presentation. We are so grateful that you were with us today and sharing your knowledge. And what I loved was your personal aspects that you added to it, your own experiences and what you know from what you've done in the past. We just want to thank you so much. This last page here today has our information for your evaluation. We'd love you guys to get your CME credits. So if you want to just browse to our SurveyMonkey link, you can finish out the survey, and immediately after we'll be able to claim your CME credits. We're going to leave this page up for a few minutes so that you can click through and fill out your evaluation. If you have any thoughts that you want to convey to Denise, you can fill them in this chat right here in the public chat. So go ahead and write them down. We also have the notes from her PowerPoint down on the right. So you can have the notes from her PowerPoint if there's any pieces that you wanted to look at again. But we want to just say thank you for all of you coming out today and viewing our webinar. We are excited to finish out this series, so if you haven't already, go ahead and sign up for the rest of this series. It'll be going until June. So thank you so much for your time today, and I hope that you have a wonderful day. Alrighty.